Hi, I'm Claire Brindis, and I'm the director of the Philip R. Lee Institute for Health Policy Studies. And today it gives me great pleasure to welcome Dr. Robert Califf to the UCSF campus. I wanted to share with you a little bit about Rob's background. He is the Vice Chancellor for Health Data Science and the Director of the Center for Integrated Health Data Science at Duke Health. He's also the Donald Wharton Professor of Cardiology at the Duke University School of Medicine. Prior to that, Rob served under President Obama as the FDA Commissioner between the year 2016 and 2017. And before he became Commissioner, he was Deputy Commissioner for Medical Products and Tobacco. Rob went to the FDA from serving at Duke as a Professor of Medicine and the founding director of the Duke Clinical Research Institute. Last year in June, Rob joined the senior management team at the Verily Life Sciences. So I'm really delighted that Rob has joined us here.
Thanks, Claire. It's great to be here.
And thrilled to have this opportunity to ask you a number of questions that intersect between big data interests that you're working on, as well as where we're heading with the healthcare system in general. And as you know, there's been a lot of attention around the triple aim, but I'm also really thinking about the quadruple aim, which is really about changing healthcare value, reducing healthcare costs, focusing on patient-centered care, as well as population health being the fourth. And I wanted to get a sense from you, taking each of these components separately, as to where you see the progress that has been made in thinking through about how we switch from or evolve from a fee-for-service system into a more value-oriented system.
Well, I'd start by saying the theory has advanced considerably. In fact, it seems like, regardless of political party now, the general statement that we need to move to a value-based healthcare system is pretty much accepted. In practice, we haven't come very far at this point, so we have a lot of work to do.
Mm-hmm. And have you seen any areas where we've made greater progress, for example, in cardiology or orthopedics, or in terms of having bundled payments?
Well, bundled payments is a good start, but I think a lot of people would say until you have a whole system where the incentives are aligned, you're going to have trouble. And, recently went back and actually read the original work of Michael Porter and Don Berwick just to sort of get regrounded. I think they nailed a lot of things really well when they wrote those early articles. Mm-hmm. One of the points that Porter made that really resonates now is that people tend to measure the things that they have control over. So if you look at overall health outcomes, a bundle payment, for example, for a post-heart attack patient may be good in the short term, but if what you're doing is moving resources from another place that's needed into that particular bundle to make it better, it may not be for the good overall. So I think these bundle payments give us a way to think about value for particular slices of the elephant, but it's sort of like the blind man and the elephant. Until we look at the whole elephant, I don't think we're going to get there.
Mm-hmm. And part of the triple aim is really looking at patient-centered care, and that's been an area that I think has been very challenging for healthcare systems. And could you comment a little bit about where we are with that? Where do you think the consumer is these days?
Well, it's another place where the rhetoric has moved along a lot. I mean, you can't go anywhere without patient centricity being part of the discussion. And one thing I really saw vividly at the FDA is that when people are healthy and they're feeling good, they really do behave like consumers. They're not interested in taking a lot of risks. They want to make their own decisions. Autonomy is a treasured principle in our society. But when people get sick, things change. They're willing to take a lot more risk. They become a lot more dependent. And the sharing of decision making with a healthcare provider becomes a much bigger issue. But as long as we have fee-for-service, it's going to be hard for healthcare systems and for doctors and teams of people who deliver healthcare to really switch into the mode of being truly patient-centered.
And the incentives clearly are not in the right place at the current moment?
Well, of course, this is my personal view, and it was sort of a mantra in the Obama HHS that if we could get payments more than 50% not fee for service, that the system would change considerably. I think an interesting segue into this is what Amazon has said they're going to do. And none of this has happened yet, but as they look at their own employees, and obviously a lot of smart people at Berkshire Hathaway and J.P. Morgan, they're interested in the health of their employees. What they see is a system that's very hard to navigate, not centered necessarily on the well-being of their employees, but sort of this mix of things that relate to how a healthcare system pays for itself in the current system. And so their view would be if you took control of it and said, we're going to align the incentives for those who provide healthcare, so the happier our employees are, the healthier they are, the better the providers will be, those providing healthcare. It would change a lot. For example, a very high proportion of healthcare would be done at home, not in a clinic or a hospital. These things are not new. They're not new concepts. People have talked about them for a long time. But if you look at the American system today, we're just not there. So some examples where big employers who have the power to do it take it on, I think will give us some good examples.
And maybe we can learn from that. There's been a lot of interest in making a healthcare system much more of a learning site, and that's obviously where your interest in big data and where you've seen the integration of data being a very important element. Can you shed some light for us on learning systems and the role of big data and how you see this unfolding?
Well, I guess this is my theme for the day, that there's not a lack of knowledge about what needs to be done. And the technology now is here to really do it. And things we used to dream about in the 70s when we had our first computerized databases, where we could take one problem like bypass surgery and just study the hell out of it for, years. And then we could actually sit down at a computer with a patient and say, do you want surgery or medicine? Here's what you can expect with each option. Show them the picture, have a lot of confidence in the data. My first article in 1981, I predicted we would be doing this with every disease by 1986. And here we are, we're, still at the beginning phase. And I think a large part of it was technology until recently, but the change in computing, the ability to aggregate large amounts of information, the loss of geographic space as an issue. I still remember one of the big technology advances that made a difference in evidence-based medicine was the fax machine. Before we had the internet to depend on, it was really the fax machine that allowed people in different places to move information relatively quickly. It was on sheets of paper, but at least you could do it, and that was enormous in cardiology. It enabled us to do very large clinical trials and get the answer and move on, which is what you need to do. But now there's no technical limitation to learning in real time with almost no latency of data.
Mm-hmm.
In fact, that's the way big business works. It's the way Amazon and Google and Walmart all work. It doesn't matter where you are. If you're touching the system, you have a digital footprint, and learning is happening continuously in that digital footprint. We're obviously not there in healthcare at this point.
Right. So how do you think clinicians can differentiate the noise of big data from what is clinically useful?
Well, it's going to take a while, and there have to be multiple fronts. It is a big issue that you have such a large amount of data, much of it not collected for the purpose of informing better shared care of people. Our electronic health records now, I think we all know, are a mess because they're essentially billing instruments, and there's a lot you can do with them, but you have to do a lot of curation to fix it. One thing I followed pretty closely, it relates to some things that go on in the Bay Area. Flatiron, which is this company that was started by ex-Googlers, And my interpretation of it was the idea originally was you could take data from oncology practices, apply a lot of technology, sort it out, and learn from it. What ended up happening was the technology turned out to be very useful, but the final step it actually took was a bunch of oncologists in a room with their sleeves rolled up, hand curating the information to make it useful. And I noticed there's just an article in Health Affairs this week, I think, about taking family practices and doing the test. Could you derive quality measures directly from the electronic health record? And at least this one study concluded you can't at this point. So a lot of effort needs to be put into curation of data. I'm afraid for me a lot of the bad things just emanate from fee-for-service. Because one of the components that I heard that's in the documents related to Amazon is if you weren't having to deal with fee-for-service, you could create a record that was about patient care and interchange between clinicians and patients as the primary interest, not creating a bill for a relatively arcane system. So all those things need to be worked on.
So in the past, our clinical data systems have been very, quote unquote, traditional in terms of focusing really on clinical care. And there's been a lot of interest in social determinants of health and how really that comprises such a big proportion of what constitutes health and well-being. Do you see in the work that you've been doing an expansion when we talk about integrated data? Do you see efforts to expand into social determinants of health and taking that into account in our clinical care?
Yeah, so the analogy I've been using lately, which is a little proprietary, but I use maps. So, if I told you in 2007 that you're going to get into your car, you'll talk to your car about where you want to go. Your car will talk back to you. And what your car says to you will change instantaneously based on the integration of information across the entire country. So, that if you're going to a city 600 miles away, it's going to change your route based on what's happening at every step in between. And that's the integration of an enormous amount of data for a specific purpose to get you where you want to go. And it's interactive. It's not sort of a fixed thing where you analyze it and then come back a year later and figure out what to do next. So if you look at data about people and their health, it's been known a long time the social determinants are dominant. The average person will spend about 1% of their time in a hospital or clinic unless they work in one. It's the other 99% that are most important. We were recently visited by a very large insurer. They had just done an analysis of all of their data for health outcomes. The two dominant factors were zip code and credit rating. Not genetics, not clinical data of various types, but really the social determinants. So if you look at it then on the sort of, as I think of it, on the one sphere we have this explosion of knowledge about biology, which is occurring, and we can now measure that like the whole genome sequencing, which is going to be part of the clinical record soon. That's like 3.2 billion tests done at once in every person. As we discussed before, if we get the electronic health records configured better, that'll be better. But the big explosion of information is out in behavior, social interactions, geospatial knowledge, where you live and how that changes over time. And it was unthinkable that you could measure that until recently, but obviously you can. And advertisers are using it every day.
And they can predict what we're going to buy next.
That's exactly right. So if we can do that for what you're going to buy, maybe we can turn that information into something that helps you live longer and become
what
more
you should
functional.
be eating or
Yes.
not smoking, et cetera. So when you were at Duke earlier as the director of the Clinical and Translational Sciences program, Duke really did a lot to partner with communities around improving health outcomes. And this is a challenge. It's, if it was easy, it would have been done a long time ago. So I'm just wondering, since many other communities across the country are trying to look at this intersection between health and social determinants, are there any special insights that you could share with us about things that, in hindsight, you would recommend to others embarking on such a journey?
I wish I could say I had really special insights. I think most of the magic of it, if there is magic, is things that people have talked about. And I'd say that the number one thing is actually human interaction. It's actually showing up and spending enough time with people that they can not just read about it, but actually feel palpably that you're interested in their well-being. And, that's pretty grimy work. It takes a lot of time. You need teams of people that are committed and persuasive. But what I think has changed, it's been dramatic since we started that work. We had this unusual situation in North Carolina where it's sort of like the basketball situation. Duke has a monopoly in Durham County, and UNC has a monopoly in Orange County, right in the very next county. And it's not illegal because the service area encompasses both, and there's some other health systems over in Raleigh. But it meant that we had over 250,000 people who all had the same electronic health record and who all lived in the same community, and we had very detailed information. We had Marilyn Miranda, who had sent students around the old-fashioned version of what Google does now. They just looked at every house and wrote down the attributes of the housing so we could locate people to where they lived.
So even within the same zip code,
right,
there's variation.
And there's variation by street and within neighborhoods. It's really quite remarkable. One thing that's happening at Google now, as you know, the reason Maps works, as I said, is they took the time to make a map of every street in the U.S. and a picture of every house. Like it or not, it's legal to do that. It enables you to really look potentially in great detail, even at the environment. The little cars that take pictures of houses are ingesting the environment now in some places, and you see pretty big differences from one end of the street to the other, depending on a number of factors. So the big change is the ease of access to data. And I think one principle that we were able to use in Durham County is showing people their data in a fair and honest way, I think has a big impact. I still remember when there's a town gown problem at Duke, just like every university has, and one of the more antagonistic people historically at a public meeting, I didn't know what she was going to say when she got up, but she said, "It's about time you showed us what you knew about us." And I think that was very meaningful to everybody else in the room and should be very motivating. It does bring up the issue about, what's the responsibility at various levels. There's a tendency, and I don't completely understand it, for everyone involved to say it's sort of someone else's problem. But it's pretty easy to figure out where the wealth and the power lies in the United States now. Very obvious to me as FDA commissioner, academic medical centers actually have enormous power. In most parts of the U.S., they're the biggest employers, the wealthiest institutions, and the most persuasive people, and they're very good. You can't call it lobbying because it's not for profit. They're very good at, I'll just say, transmitting their message to politicians and legislators. So part of what I want to say today is the big universities and academic medical centers need to make a shift, I think, to take into account the fact that we have a lot of this country headed the wrong direction. And in health, and you could argue in other ways, but it's very measurable in health. And we need to use that talent and intelligence to do something about it.
So we really need to mobilize and marshal that energy in a different...
Yeah, and I think the great thing is, in the past you could say, well, that's just ideology and you have beliefs, but now we actually have the data. And, you know, on average, California's better off than almost any other state. But within California, there are enormous disparities, and you just can't ignore them, because you used to say, well, you know, I know you talk about this. Now you can, in real time, actually show what's happening to people. And we should be able to try various ways of fixing it and then measure it and fix it again and involve them. You know, one way, politicians are another group that need to be accountable. One good way to hold politicians accountable, I think, is to show their constituents the pictures of what it's like. If you live in a neighborhood that's living on average 5 years shorter than the neighborhood next door, which is common in the U.S., maybe you ought to all work together to do something about it.
Well, that's a charge. It's definitely a challenge. I just have a couple more questions. During the time that you were at the FDA, before you were the commissioner, you obviously spent a lot of time focusing on tobacco. And this still constitutes one of the #1 public health problems in our country, along with, I would argue, obesity is another factor, major factor. Do you see trends? I worry a lot about e-cigarettes and young people and the controversies around these issues. And do you have in your crystal ball, can you tell us sort of where you think we're heading?
Yeah, you know, it's an amazing experience for me, because as a cardiologist, I'd seen so many people die directly related to smoking. I just assumed that tobacco was bad and that, you know, it was on the way out. And it was a real wake-up call to arrive at the FDA with the Tobacco Center reporting to me, and to really be able to dive deeply into the science and the epidemiology and the social issues. What I'd say is, you know, we learned at the time of the revelation of the secret notes in the tobacco industry that the nicotine levels in the tobacco leaf had been ratcheted up through old-fashioned genetic engineering. The way most plants historically have been cultivated for decades is through seed irradiation, and then you cultivate the plants for whatever attribute they want. And it was very deliberately done to addict as many people as possible. The quotes about customers for life and replacement customers for people who were dying. And so it only makes sense that you could ratchet the nicotine level down in the leaf deliberately as a policy. The FDA has the power to do that. And I'll have to say, you know, we tried to do it, but we couldn't get it through in the Obama administration. And I was pretty excited that Scott Gottlieb, the current commissioner, announced that that's going to happen. Then you have the issue of the vaping industry and e-cigarettes, probably the fastest growing small business in the U.S. over the last 5 to 10 years. A lot of employment involved, but nicotine is highly addictive. And so I think we do have a public health dilemma. The UK has pretty much decided that advocating e-cigarettes for getting people off of regular tobacco is a public health benefit. The data is not entirely clear, and there's a lot in the balance in what we decide to do with the e-cigarette part of this. It was obvious to me when we were talking about, I would not want to be FDA commissioner if there was no good replacement and you suddenly took the nicotine out of the leaf for 32 million people, which is the number of people. You'll have some really angry people withdrawing from nicotine. So the part of it I like is a policy of, I don't think many people are going to want to smoke if they're not getting the nicotine fix. That will save a lot of lives, I'm sure of it. Now we've really got to focus on what to do about e-cigarettes. The really good news in the Tobacco Act is that the FDA gets a lot of money for research, and I would urge young people who are interested in research, the funding levels are better than almost any other area because there's dedicated money for it. We got a lot to learn about that part of it.
Great, thank you so much. Just to close our conversation, our far-reaching conversation, I was just wondering if there's any other comments you'd like to make about sort of the state of the state, and how do you think, or what do you think we would really need? You comment in terms of shifting our focus. You've quoted and you've commented on the importance of big data in shaping clinical practice and shaping what we do in communities, in our partnerships with communities, in our partnerships with our patients when they are there at the bedside, but also in the community level. And this shift in values within our country is really a big dilemma, a big moral dilemma. And I'm hoping that we can get there without violence or without, but some other kind of social movement. Do you have any tea leaves that you can look at in terms of?
I don't have tea leaves, but I do think the number one issue for universities today, this obviously just my opinion, it's the reason I am half-time, you know, out in Silicon Valley and half-time in North Carolina at a university that has a big regional and maybe national or global impact. We got to figure out the rules of the road. So now we have this amazing ability to communicate with everybody in the world simultaneously. We have the ability to measure things, you know, without going into detail. It's obvious if you're just carrying a cell phone, we know we can know a lot about you, and that can either be used for good or bad purposes. One can argue that over the last few years, the bad has sort of been winning. There's a great study just published that shows that untruths travel to more people faster and last longer than truthful statements on the internet. So the national policies or global policies related to the use of this information, I think, may turn out to be the deciding factor. And to get it right, you can't depend on politicians because, you know, they're not experts. You need an eclectic mix of things like law, public policy, health, sociology, philosophy, religion. They all need to be brought to bear, and universities have all those elements in one place with a societal mission. But I don't feel like, for some reason, universities have not taken this up. But we're all being affected by it. And I think it's a wonderful, we could fix a lot of this by, as I say, measuring things, trying interventions, measuring again, and you can do it very quickly now because the data are there. But we've got to get to the point where what's on the internet can be relied upon and truthful without squashing the First Amendment right to speak, which is, I think, something we all believe in.
Okay. Well, thank you so much for your time, and really delightful to have this opportunity to be interviewing you.
Looking forward to the day at UCSF.
Thanks very much.